So I've worked in healthcare for 20 plus years in tons of health systems. And in the last 5 years, particularly on patient access and digital health implementations. And across all of them, I see the same five failure patterns. Not 10, not 20, five. So if you're a health system leader and you're wondering why your last tech investment didn't deliver what the pilot promised, at least one of these five patterns is the reason. So let's go through them. First, pattern one, buying a solution before diagnosing the problem. So this is the most common one. A health system identifies an access problem, long wait times, low portal adoption, poor no-show rates, and immediately moves to vendor selection. They do demos, they issue an RFP, they select a platform. What they don't do is honestly assess their current state before they start spending money. So the result is that they invest in a scheduling platform when the real problem is care management, or they build a digital front door when the bottleneck is change readiness. The tech works as designed. It just doesn't work for the problem they actually have. So the fix is a pre-decision diagnostic. In my framework, that's the 5-pillar access audit. So 10 minutes, 5-dimension assessment that maps where you actually are before you decide what to buy. So I'll put that in the link below. Number 2, confusing pilot success with scale readiness. A pilot succeeds because of the conditions that don't exist in the rest of your system. I said it. Dedicated project management, a clinical champion with protected time, steering committee meetings every week, a vendor who's treating your pilot like their most important reference account ever. That's infrastructure that's real. It's also very temporary. So when the pilot ends, that infrastructure evaporates. And if nobody built a scale strategy while the pilot was running, you now have a system where one unit uses the tech and the other 30 don't. So I call this pilotitis. The solution isn't to run a better pilot. The solution is to design the scale architecture before the pilot even launches, not after it succeeds. Number 3, under investigating the change readiness. Number 3, under investing in change readiness. I assess health systems across 5 pillars. Change readiness. Pillar 5 scores lowest with the near statistical consistency. Pattern 3, underinvestment in change readiness. I assess health systems across 5 pillars. Change readiness, pillar 5, scores with near statistical consistency, not technology, not data infrastructure, change readiness. And this is your organization's structural capacity to absorb improvements. So that means dedicated bandwidth, protected clinical champion time, clear escalation paths, internal change management expertise, and almost no health system budgets for this explicitly. So it gets absorbed into implementation costs or assigned to someone already running at full capacity. So when change readiness is low, it doesn't matter how good the tech is. The implementation is going to underperform. The tech's going to plateau, and leadership will wonder why their $3 million investment is producing a 6% improvement in the metric they cared about. So a quick pause. If you want to score your own system across all 5 pillars, including change readiness, the 5-pillar access audit is free. It takes 10 minutes, and the link is below. So back to the patterns. Pattern 4, building for the patient who already knows how to navigate healthcare. So this one is subtler, but I think it's the most damaging at scale. Every digital health tool I've seen is designed for the patient who's already comfortable with tech, already familiar with how the health systems work, and already motivated to engage digitally. And that patient is roughly 35% of your patient population. The other 65% are navigating your system for the first time, or managing complex conditions across multiple specialists, or dealing with competing priorities that make portal adoption the seriously lowest priority ever. So when you build your digital front door for the 35%, you get strong adoption metrics among users who would have found you anyway. And you leave 65% of your patient population with 4 phone numbers and a confusing discharge summary. So better design means designing for the patient who is navigating a health system for the first time, not the one who's already good at it. Pattern 5, the leadership team can't see the whole picture. Most health system leaders are operating with fragmented visibility. They can see appointment volume, they can see digital adoption rates, they can see individual clinical metrics, but what they often can't see is whether those metrics are actually connected. Whether a 22% increase in digital appointment starts is actually translating into completed care plans and improved patient outcomes. Whether the pillar they just invested in is the constraint, or whether fixing it just moved the constraint to a different pillar. Access improvement requires systems level visibility. The data usually exists. The dashboards that connect it rarely do. And this is the thing I'll be talking about at Grand Rounds on April 8th, what it looks like to actually see the whole picture, not just the metrics that happen to be in your EHR. So, 5 patterns: buy before you diagnose, confuse pilot success with scale readiness, underinvestment in change readiness, design for the wrong patient, operate without systems level visibility. If you're seeing yourself in any of these, the first step is the diagnostic. The 5-pillar access audit, it's free, it takes 10 minutes, and will tell you which pattern applies to your system. The link is below. So if you're already past the diagnostic stage and you're circling a stalled implementation or an access strategy that isn't moving, that's the conversation I'm having with health systems right now. So my Calendly link is also below. I'd love to see you. And you know what? Maybe I'll see you in the next one.